If we look at system-wide, we performed 873,819 tests, tested 486,505 people with a total positive percentage of 17.5%. And at Just Baptist Memphis, we've tested 71,963 people with a positive rate of 10.8%. If we look at the present hospitalizations, we can see some very nice relief coming. The numbers have come down significantly since last week, and that is we have a total of 55 inpatients with COVID-19 in non-ICU setting, and we have 24 people at Baptist Memphis with COVID-19 in the intensive care units, for a total of 79 people at the moment hospitalized at Baptist Memphis with COVID-19. 19 of those 24 people in the ICU are on ventilators. If we look at Baptist DeSoto, there are 49 people in acute care non-ICU settings with COVID, and there are 21 people in the ICU with COVID-19, for a total of 70 people in the hospital with COVID-19 there. 15 of those 21 ICU patients are currently on the ventilator. If we look at fully vaccinated people, you can see the total number of admissions going down. There were 2 admits with COVID-19 at Baptist Memphis over the last 24 hours, and one of those 2 admissions was fully vaccinated. There were 7 admitted to Baptist DeSoto over the last 24 hours, and only one of those 7 was fully vaccinated. If you look at the total number out of the 79 people at Baptist Memphis, there are 5 currently in the hospital who are fully vaccinated, and 4 of those 70 people at Baptist DeSoto are fully vaccinated as well. So those are the numbers. It is, I will say, just to describe it, in the last week, it has been really encouraging because there's a bit of room to breathe. We see less ICU bed congestion, and there's a big difference between 152 people in your hospital, which we had a few weeks ago, and 79. So to get below 80. It's still way too many. We still have, unfortunately, people that are dying of the infection because those are folks who've been in the hospital for a long time. And particularly with this younger population, unfortunately, that death curve is going to play out in a longer period of time. You still see that here at Baptist Memphis, 19 of our 24 ICU patients are on the ventilator. So there's still a lot of people at risk of complications and death. And obviously, that's the ultimate thing that we want to avoid. But that'll be something that we have to be dealing with for probably a few weeks to come. So happy to answer any questions if there are any.
Hey, Dr. Threlkeld, it's Corinne. How are you today?
Okay, Corinne, how are you?
I'm doing all right. So nationally, it seems like there's been an uptick, very slight, but still an uptick in the number of breakthrough cases who are being hospitalized or dying. Are you seeing that here? And are a lot of the fully vaccinated people you're treating the same type of people, elderly, pre-existing conditions, et cetera, that we've been seeing all along?
Yeah, it's a good question. We certainly have seen, and you may remember at the very beginning of the Delta wave, I made the observation, there are more people who are breaking through from vaccinated status to be reinfected here than we had seen ever before, even cumulatively in that regard. But yeah, what we've seen is almost everybody in the hospital who is sick enough to be particularly in the ICU, and further, particularly anybody who dies of this infection, has really been someone who we would expect not to have a great response to the vaccine. Transplant patients, other people heavily immunosuppressed on steroids for things like lupus and the like, and the elderly, and people, it turns out, who've been vaccinated the longest time ago. So what we're starting to see very possibly is the same thing that was seen in Israel. That would be the likely expectation. But it is still the case that the vast majority of people in our ICUs are unvaccinated. But yes, we definitely do see a few even deaths in previously vaccinated people in varying stages of immunosuppression. There are a few that are not terribly immunosuppressed. We've seen that going back even to the Alpha variant days in small numbers, to be sure. But I think that we expect, given what we've seen that drove us to move toward the vaccine boosters, we expect to see those numbers go up gradually. Certainly, in less severe cases, it's being seen and was really predicted. But the concern is that in younger populations, even, we'll see more and more serious cases as immunity wanes from the vaccination. But yes, the ultimate answer is almost everybody still is unvaccinated, and the people that are breaking through and having more severe cases and unfortunately deaths tend to be people who are the oldest and the people who had their vaccine the longest ago, and or immune suppressed folks. And the immune suppressed folks we've always known obviously would be a problem, and that was really the first group to be approved for the for the booster, or for a third shot, I should say, to get immunity in those people. But it's also important, I think, to point out that we've seen quite a few people die who've had the infection before. Whether they've been vaccinated or not, really, almost all those people have not been vaccinated. So we have had a couple people die in the last couple of weeks who had the infection months before and had chosen not to get vaccinated because of that. And that's a mistake that I sort of urge people not to make. It is true that immunity from having had the virus is pretty good. There's no question about that. But nothing is as good as having had the virus and have the vaccine on top of that. Now, it would be nonsensical to go out and then, having both is the ultimate way to be protected. It would be nonsensical to go out and try to get infected just to have better immunity against the infection, of course. That would be a bad play. But if you have been infected and you have a vaccine on top of that, that really is probably the best situation. Such that, just as a corollary to that, the idea of the booster shot, it's not exactly clear, and the CDC has not made any recommendation on whether you should get a booster if you had been fully vaccinated and then subsequently infected and had a breakthrough case. There really is no clear recommendation yet that you even need a booster. Now, there'll be further data that come out on that. No one has said for sure that you don't. But right now, the CDC is studying that and has not made any kind of full recommendation to go out and get a booster vaccine if you've both had infection and had full vaccination status.
The other thing I wanted to ask you about was actually flu season coming up. So when should people get their flu shots? I know last year you said you don't want to get them too early and then have your immunity wane on the tail end of flu season. So when should people be getting their shots? And do you expect to see another milder flu season like last year, since, hopefully a lot of people are still taking the precautionary measures, hand washing, masking, etc.?
Yeah, it is the question, I think, one of the most important questions that we face right now. I think it's a real wild card what we're going to see for this winter. We had essentially no meaningful outbreaks of influenza last year. That was great. Weirdly, that was used sometimes in talking to me about, people would talk to me about, well, this shows that this whole thing is sort of a hoax because we didn't have any flu. And I'm not quite sure I ever understood that objection, because if you do the behaviors to knock out the more contagious virus, even in coronavirus, you certainly are going to have an impact on influenza. And so last year was inconsequential, comparatively speaking, with the flu. But 22,000 some odd people died the year before the flu. We don't have any real historical perspective to be able to say what's going to happen this coming year with the flu. It may be that this will be significantly more severe because we went a year without really seeing it. It may be that our immunity will have 2 years to catch up with mutations that, albeit weren't here very much, they may still have made those mutations. It may be farther away from the previous virus. So there are a lot of wild cards to look at. Ordinarily, in the Memphis area, I think the issue of waning immunity if you get vaccinated too early is a real one, because we tend to, for whatever reason, and I'm not sure what the reason is, we tend to have a later peak here. Sometimes there'll be a small peak in November, and then the usual main body will be on into February, March, sometimes even April. So they tend to be on the late side from what we can see. Some of that is ameliorated in the older people by getting a higher dose of vaccine that we see for folks in the older age groups. But I think this year is more confusing. We might see an earlier peak. This may not obey the rules that we normally see. We've seen this in respiratory syncytial virus, RSV. We're seeing outbreaks in kids in late summer, and it's usually pretty much a wintertime disease. So we don't really know what the rules are going to be this winter. So I'm not recommending that people wait too long. Certainly, once you get into the end of September and into the 1st of October, now is the time. I would get both a coronavirus vaccine, a booster if you're eligible for it, and I would get a flu vaccine. This year may be the most important for a flu vaccine in many years for two main reasons. Number one, what we just mentioned, it may be more severe. We really don't know how it's going to behave. And secondly, it's going to put its own strange stress on the healthcare system. Just as coronavirus is waning, thankfully, here particularly, there would be some other areas of the country that may see a bit more increased cases. But here in the Southeast, those numbers are waning, but that could potentially be balanced by influenza outbreaks. And it is, nearly impossible to tell the difference between COVID-19 and the flu for the average person experiencing respiratory symptoms and fever and headache. Either can do all of those things. And so it stands to put extra stress back on the healthcare system that we experience to be waning right now. So if you take a disease that's going to kill 40, 50,000 people this year in the flu, if that's the way it turns out, then it's going to lead to confusion and a lot more congestion in the healthcare system, in addition just to being the tragedy that it is. So I think this year, more than ever, it's going to be important to get a flu vaccine and to get it relatively early, meaning now, because it probably is a mistake on most years to get it way back into August if it's available, because it could wane. At this point, I think it is time to do it. And again, it probably is the right moment to make the statement again that it is reasonable to get the flu shot and the COVID-19 shot if you haven't gotten one at the same time. There was a little confusion about that because people were so worried about making sure that side effects from the coronavirus vaccine or COVID-19 vaccine were really from that vaccine and not from something else, that the initial recommendation was to separate the COVID-19 vaccine from anything else by 2 weeks. That has since been withdrawn because we now have enough data to know what the side effects are of the vaccine. So you can get both at the same time. In fairness, that's not been studied with the third shot and flu vaccines at the same time. But we've seen pretty much in the preliminary data that the side effects from the third shot are pretty much equivalent to the side effects from the second shot. So anybody that needs both should probably get both. The time to get your flu shot is whenever you can.
Last question I have for you today, and I'm pretty sure I know the answer to this one, but it's good if you say it. If you are feeling flu-like symptoms, should you go get tested for COVID-19 and not just sit back and assume you have the flu?
Yes, as you probably, I hope, anticipated an affirmative answer. I think that is true, particularly this year, because remember, a lot of the high-risk groups are the same: the elderly and people with immune system problems, other underlying illnesses. So remember, those people are eligible for monoclonal antibody therapies and some things that may cut down the likelihood of you experiencing severe disease. Not to mention, they're eligible for oseltamivir or Tamiflu to take for their influenza. So either of these diseases can kill you. It turns out that COVID-19 even much more likely than the flu, but both of these diseases can be very, very dangerous in folks who are immunosuppressed, elderly, and the like. So I think it's very important to try to do testing. And remember, we have flu tests too. Kind of like the rapid coronavirus tests, they aren't perfect. They can be down in the 70% range of finding those infections if you're doing the routine screens that you're likely to find in physician offices, places like that. Although some of the DNA screens, RNA screens, the molecular testing can be fairly good at finding that, and they're very specific. If you see it, you really have it. There are very few false positives. So you can be tested for both or either, and either of those things can be important because we now have therapies to give to some people. We hope by the end of the year, just as a separate topic altogether, that we'll even have some oral options kind of like Tamiflu for COVID-19, a different matter, but it's going to be important this winter, if we can, to find out which of these diseases that you have. You don't want to be around other people with either one of them, but there are degrees of difficulty that we need to look into. And we just don't want the situation, when it really comes right down to it, all of the sort of arguments and discussions about this, a lot of it has come down to, yes, we want to protect everybody from this, but we also wanted to blunt the curve. And we think about that every year to a lower extent with the influenza epidemics. People die because they have these infections, but the numbers have been high enough where people have died because of other spin-off problems related to the infections. We don't want people to have problems with getting to their health care, with backup of cases in doctors' offices and hospitals and inability to do some of those things. Remember back when we have had to cut back elective procedures, cancer screenings have gone down, even vaccines for other preventable diseases in children. There are many, many spin-off problems here that we won't even fully realize or appreciate until months go by. And there'll be some pieces to pick up based on the difficulties that have spun off from certainly the COVID pandemic. And if we combine flu with it, it can just add to that problem temporarily.
You were going to talk about Regeneron, the antibody cocktail, and how it's different from the antibody treatment and whether it's available.
Yeah, so monoclonal antibodies, and it turns out that it's made a fair amount of news just because the WHO has begun to push it more aggressively as an approved therapy. And of course, what we're talking about, the monoclonal antibody cocktail, is the current form of the available monoclonal antibody. We started out with bamlanivimab, a Lilly product that was quite effective, but eventually the mutations and variants became more resistant to that particular monoclonal antibody. So really the Regeneron product, called RegenCove is its trade name. It's a combination of two different monoclonal antibodies. Casirivimab and imdevimab are the names of the two particular antibodies, but they are combined together, presumably to cut back the possibility of resistance. And I think, there's been a lot of news about it. There's been potential for shortage, and there was a kind of a political small fight over the fact that the southeastern states have used arguably more than our share of the national supply of monoclonal antibody. And so there was a situation to limit the availability on a per state basis, so that the idea was that if you didn't get your vaccine, that we didn't need to be using monoclonal antibody as a secondary line rather than getting vaccine. And that was sort of accusation is a strong word, but that was certainly part of the discussion. So there's been concern in our state and others around us that there might be a limited supply of the monoclonal antibody. It turns out we've not experienced that yet. I think part of that is that earlier here in the Delta surge, people really pushed to get the monoclonal antibody therapy and the Regeneron product, but that seems to even be waning a bit now. We still have adequate supply right now of monoclonal antibody therapies. We hope it will stay that way. We're fairly optimistic about it simply because the numbers, as we mentioned, in fact, are falling in this part of the country after having experienced what we hope is the final peak of the surge. So it's still, however, a very effective therapy if you come down with COVID-19 and you are in one of those groups, either by age, overweight, diabetes, pregnant, sickle cell, heart and lung diseases. There are a number of things out there that would predispose you, and you can check with your healthcare provider about whether you might be in one of those groups. That would make that a very reasonable maneuver for you, because it does cut down by up to 70% the likelihood that you would, in one of those high-risk groups, progress onto the more serious form of the disease, like hospitalization and death from pulmonary problems. So it's certainly worth checking into. Where the state came down most recently was to suggest that we probably weren't going to be utilizing it as much in people who had been fully vaccinated. That is a gray area and a fluid sort of process. We certainly have given it to people who are fully vaccinated. It's a matter of stratified risk. So if you have problems, check with your primary provider. They can check with any of us at the infusion center who can kind of talk it through and see if that might be a person even vaccinated who would be at risk just because of immunosuppression, for example, where you wouldn't expect a good response to the vaccine. Those people would be people you would want to push ahead with that. So still a very important therapy. We hope it will be less necessary because the cases will be dropping as more and more people have had the infection and certainly have been vaccinated as well and protected from it.
And speaking of having to use it less, talk about that antiviral that they're working on.
Oh, yeah. There are actually 3 different antivirals that are currently in the pipeline of clinical trials into phase 2 and 3 trials. If we look back, and there's been a very interesting history of the antivirals. Obviously, remdesivir was the first one approved, but didn't have maximum impact because its efficacy was somewhat limited. And the approval, at first by EUA, and now full approval, was really limited to people who dropped their oxygen levels and needed to be in the hospital. So it wasn't very practical. I will say as an aside that there are some data that had been released by the company that showed that remdesivir was actually quite effective, on par even with the monoclonal antibody therapies, cutting down things by 70% protection. If it was given in 3 daily IV infusions as an outpatient earlier in the course of the disease. It is not approved for that yet, but they may very well apply for such approval. The nice thing about it is it would be one of the very few things that we could give early on in disease that helps. Steroids only help later. Remdesivir is only itself approved for later. And really only the monoclonal antibody at $2,000 a shot is really available for people to improve their lot early on in infection. So so the more that we could have early on in disease would be a game changer, particularly if it was easy to get to people, like a pill. So the first pill, probably the one that is the farthest along in the process of research, is a drug called molnupiravir that's being developed by Merck. Interestingly, it was developed preliminarily at Emory in Atlanta in its early stages. It was looked at for more of a broad antiviral agent, I think including influenza even in its scope, but it was found to have quite good activity against coronaviruses. And so it's being looked at now in a phase 3 trial. And there are those who suggest that these trial data will be out pretty quickly. It has even been estimated that we could have EUA or emergency use authorization for such a drug as early as the end of the year. And that really would be a game changer, to be able to provide people with a pill to take that would cut their chance of having more severe illness, and to be given earlier on in disease. Again, I think a real game changer. There are a couple of other products out there that are now either just entering or are already in phase 2-3 trials. One is from Pfizer and one from Alea, two different companies that are making oral medications. Remember that those phases have to be traversed. The phase 1 really looks at safety at different doses. Phase 2 gets into larger numbers of patients to be tested and looks a little more at efficacy along the way. And then phase 3 are the larger tens of thousands of people in those trials showing safety and efficacy at a much larger scale in different groups, races, ethnic groups, gender, and very importantly, age, because we can see some differences, particularly in age groups and those sorts of things. So we're in that stage in probably 3 agents. And what an amazing difference it would be able to make if inside of 2 years we had 3 different oral medications to give to people. It would indeed, I think, be a game changer that would really help us kind of put a nail in the coffin of this stage of the pandemic and get us back to normal. So it's an exciting thing to look at as we move forward.
And then you were going to, a couple more things you were going to correct the info about the COVID and the risk of heart inflammation, because you could.
Yeah, and so the one of the more publicized side effects, and this applies to side effects in general about the vaccine for COVID-19. The latest version of that has obviously been the heart inflammation or myocarditis. It's seen most commonly in younger males, teens to young adults. Now, just like you see regular viral myocarditis, there's something called a Coxsackie virus that's a common sort of viral infection in folks, and that one is one of the ones that commonly causes these viral myocarditis. And just like what we're seeing now, you see that more commonly in younger males as well, though it can happen to anybody. So myocarditis is a very rare problem from the vaccine. And it is one that typically people do well after a few days. Sometimes it can cause some pain, discomfort, but usually people do well. And so there was a study that just came out out of Ottawa that unfortunately became viral in social media. And it pointed out a 25 or so times higher incidence of myocarditis in the group that they were looking at in Ottawa. It turns out that group in Ottawa just were doing things, to quote them, on the run in their gathering of data, and they failed to point out that 25 times more people had received the vaccination than what they had seen in their initial gathering of their data. So really, they threw out a number that was 25 times higher on the incidence of myocarditis from COVID-19 vaccines than was the reality. Now, unfortunately, like toothpaste, once it's out of the tube, there's nothing you can do about it in a lot of ways. And so this thing made the internet and was put out in a lot of sites under the heading of "See, we told you the vaccine was much more dangerous than people were letting on. This is much higher than people have reported." And it turns out that it was not at all much higher than people had reported. It was pretty much on par with what other incidence studies had decided with myocarditis. And like other potential side effects or fears about this vaccine, myocarditis turns out to be in the category of not only is it rare, but it's much safer than facing the infection itself without vaccination. It turns out that the rate of myocarditis with COVID alone is many times higher than the rate that you would see in the vaccine. So again, it's not just that it's exaggerated in the first place, the risk. the risk is strangely much less than facing the virus itself. We saw this in some of the false rumors about pregnancy and fertility and all these things. And again, that's the irony. People spread fear about the vaccine when in fact it is just the opposite by substantial statistical margin, that you're much safer getting that vaccine even on those particular grounds than to try to face the virus, because it's more dangerous even for those side effects that we're talking about than is the vaccine. Not to mention the many other things that can go wrong if you face that infection unprotected.
And then the last thing you were going to talk about is the treating COVID at home. Some tips for anybody that's got COVID at home.
Yeah, so COVID at home is been a controversial topic for quite some time. In part because we really had little to offer for people who have COVID at home, who have the milder, earlier form of the disease. As I mentioned, if you're a high-risk person, you should avail yourself of the monoclonal antibody, and that's something, if you're positive that if you have any doubt that you could be in one of those high-risk groups, then you're better off to try to pursue that antibody and check with them about it. But aside from that, the things to do really that are shown to be effective in early COVID-19 would be, number one, stay hydrated. We want to keep from getting dehydrated. It makes everything else worse. The people that we see showing up in the hospital to be admitted are very frequently dehydrated. You lose fluids when you're coughing and sneezing and breathing harder if you're short of breath. All of those things can tend, and not to mention diarrhea and other side effects of this virus. So you can certainly see people get dehydrated. So that's something that we advise people. Secondly, don't take completely to bed because that increases the chance of blood clots. It increases sometimes the chance of pneumonia when you don't inflate your lungs well. You can feel really bad and feel very low energy, but it is helpful to get up some to the chair, move around a bit to avoid some of those other sorts of problems. And then the third one, the main one, is to get a good oxygen monitor. If you have a good oxygen monitor, that's when you know what sort of therapies are open to you. If they stay above the low 90s, then you're in good shape and are unlikely to develop more severe disease. If it starts dipping significantly to the low 90s, 90 or upper 80s, that's when you need to seek more significant attention and touch base with your healthcare provider, maybe move toward the hospital for oxygen, steroids. A whole group of therapies comes open to you. We don't want that, but we do have some other things that we can give to cut down on the severity of your illness and the likelihood that you would die of the infection. So those are the big things. The ones that are controversial, of course, would be some of the vitamin therapies, vitamin C, vitamin D, zinc. Those things really have no proven benefit. I know that people have very high emotions about those things, and I have no problem with people taking the vitamins taken at reasonable approved doses. They are fine and shouldn't cause any problem. But the reality is that there's not really a lot of evidence that they make COVID-19 any less severe. Other unproven medications we've talked about, ivermectin and the like, on several occasions. People try to get that. I'm not a fan. I've given more ivermectin than most people anyone has ever met. People in infectious disease give the drug, but very good trials have suggested that they don't work. And the one large trial that suggested that it did work was proven to be really false. It was a study from Egypt that a lot of people put a lot of stock in. The problem was that some of the people that were included in that trial, turns out, had died before the trial even started. So there was a whole lot of problem with the data. That trial was rescinded and was sort of discredited. So along with it, a lot of the larger studies that tried to include it among other studies had to kind of recount their support for ivermectin. Now, I'm all for clinical trials. There are still some clinical trials going on with ivermectin arms in it. I think that's great. If there are data out there that suggest it works, terrific. Let's see it. It's just that we don't have any yet. And they're really, as I say, I give ivermectin. I gave it about a month ago to a pre-heart transplant person who had strongyloides parasitic infection in the past. So I have nothing against the drug. It's just that you really need to show some kind of benefit before we go throwing an antiparasitic drug at this infection. And then those are the main ones. And again, I think the oral medications that are in those phase 3 trials have the potential by the end of this year to really change the game and to really make this a disease that we can more quickly get out of the the worst forms of it and move it more rapidly toward that nuisance status of being an endemic infection that looks more and more like where we're headed. By nuisance, of course, we're talking about a common cold sort of thing. There are still, unfortunately, though, a lot of people left to die of this infection who are unprotected by the vaccine, because at some point it looks like almost everybody's going to get this infection. And it's just a whole lot safer to get it if you've been vaccinated than to face it without any immune protection, because those are the people who die, and that's what we obviously want to avoid. As we're, it's the old, it's safer to go down a staircase than to jump out the window. I mean, you want to do those mitigating behaviors to keep us from having it before we get the vaccine, and we want to get the vaccine to get to that immune status to minimize the impact of the infection. Any other questions? I think there were a couple from the feed that I'll try to read very quickly, just in the interest of time. The first one is about ivermectin. I think I will make this point. Randy Hignan, why aren't doctors using ivermectin? I think we kind of went through that. And the point was made, look at India, it cleared COVID from their country with ivermectin. I mean, I would argue that that's not an accurate statement. India was torn up terribly by this pandemic, and the fact that it was already on the way out, people began to use ivermectin. The fact that it continued to go away really doesn't tell me much. That's about like putting up on your raincoat when the hurricane has already passed you and moving offshore. So I don't think there are really any data that showed efficacy. Open to see it if anybody has any, but I haven't seen any data that really changed any course in India. We'll go through these quickly because some of them we've already dealt with. There's some about flu season. Here's oral medication. Kristen Richmond asked if we've seen any antibody-dependent enhancement from the vaccine. It's a good question. I think the large answer is no. Antibody-mediated enhancement is a very specific immunologic problem where a vaccine actually increases the severity of an infection, and it does it by binding to the virus in a way that doesn't put it out of business. It doesn't inactivate it. It only sticks to it, and sometimes that makes it get to the immune cells and the white cells more efficiently than if there weren't an antibody stuck to it. But it's not a neutralizing antibody. It doesn't make the virus incapable of copying itself. So it weirdly takes the virus and approximates it more with our immune cells that can have uptake more rapidly. We see this in dengue fever, for example. A couple of the RSV vaccine attempts in the past had paradoxically increased severity after the vaccine trial, but there is no evidence whatsoever that this has happened, either biochemically and looking at things in the test tube, and we just haven't seen that. If that were the case, you would see a lot of people getting much more severe infections with COVID-19 after they've been vaccinated than before. And in fact, of course, it is dramatically and exactly opposite. Almost everybody in our ICU is someone who is unvaccinated. So good question, just something that we've not seen. People have put that out there as a concern for a vaccine early on before it had been proven and when it was still, quote, experimental, unquote. It is no longer so. It has had plenty of opportunity to demonstrate all manner of things, certainly including that one. And I think we're well beyond any sort of significant risk or concern of that sort of thing. Marty Burkett asked, have you treated anyone with side effects from the vaccine? Yes, not uncommonly. We'll see people, I mean, hospital employees and so forth, the most common ones we see because I see them every day. And anybody who's gotten their second vaccine or a booster even, they have some headache, they have a sore arm, they may feel sort of flu-like. Rarely it's enough to make someone miss work for a day or so. But that's been much less likely than we had feared when the vaccine first came out. We have not admitted anyone, to my knowledge, and the last time I checked with my infectious disease colleagues around town, the answer was that none of us had actually seen a person admitted to the hospital from vaccine side effects. If that's happened since then, I've not gotten the word from any of them. And that is a common thing. You hear these rumors all over the place on the internet that thousands of people are dying from the vaccine. It just is not true. We have seen no one. We have seen plenty of people die of having had the infection and not getting the vaccine. We've seen a lot of people admitted to the hospital who previously had the infection are now reinfected. We see very few breakthroughs in the hospital, but that does happen, to be sure. But essentially, no one have we seen that have had hospitalization from the vaccine itself. I remember, and I pointed this out before, the very first day the vaccine was available in the UK, there were 2 people, healthcare workers, I believe, coincidentally, who had severe allergic reactions, anaphylactoid reactions. They required epinephrine shots. One of them, at least, I think, had known anaphylaxis tendency and carried an EpiPen with him around. Both of those people were treated on site and went home and did fine. And in the 30 or so minutes that we were talking about it in this effort, as we were talking about COVID-19 in general, I pointed out that a few thousand people had died of COVID while we were talking about a couple of people who had a vaccine reaction that didn't need to be hospitalized and they went home and did fine. It turns out it's really rare for that to happen, but it is why people watch you for 15 minutes or so after the vaccine, because those places where you get the vaccine are all equipped to deal with rapid allergic reactions that thankfully, again, are very uncommon. Kristen Richmond asks, are you seeing drug-resistant bacteria in the hospital? We always see drug-resistant bacteria in the hospital. I wouldn't tell you that I've seen more of them for a couple of reasons. I think people are doing much more in the way of protective gear. And so when you wear gowns, gloves, that sort of thing, most of those things are spread by touch among patients in any healthcare facility potentially. And so in that sense, that probably has tended toward to decrease. It's why we don't like to give antibacterial antibiotics to people with COVID unless it's clear that they need them. We don't see too much in the way of upfront secondary bacterial infections. It's usually just viral. And so we give steroids that might very well make bacterial infections worse. So there are times when we can't tell the difference of whether or not there's a bacterial infection on top of the COVID. And so there are times when we'll give people antibacterials, but we don't like to unless it's pretty clear that that's a likely thing. So that would be the sort of thing that might increase resistant bacteria, but I wouldn't tell you that we have seen a lot more of that, in part, again, because of the protective equipment that we're wearing. Marissa Newman asked, can you clarify how long do you wait after getting the virus to get the vaccine? This, like so many other things, has been something of a moving target. We used to say 90 days because there was only one variant around and no one essentially got infected again before at least 90 days, and in general, probably a lot longer than that. So that was the original recommendation, not to bother getting the vaccine until 90 days after infection. That changed with the advent of these other variants that have hopped aboard, most recently, of course, Delta. And so the recommendation was, as soon as you get over one variant, you should go ahead and get the vaccine as soon as it's convenient for you to do so. Of course, waiting until you get out of isolation at least 10 days, and we don't want to infect the people giving you the shot. Now, that is still the recommendation, though I will absolutely agree that with no other variant closely following yet, at least on the heels of Delta, the rapidity to get a vaccine after natural infection is less of an issue. You can probably wait a bit longer because there's no Lambda, Mu, whatever you want to say, Omega variant at our doorstep right now. It's still possible, but I think the need to follow up as quickly as you can after infection is not as high as it would have been, 2 or 3 months ago, when you were really looking at maybe a previous variant natural infection, and then the Delta could come in behind it, or one of the other variants. Now that may change next week if the Gamma variant or the Mu variant comes in with some resistance to these previous infections and even to the vaccine. So getting a vaccine at that point will more quickly will again, I think, be more important. Heather Pike asked, are at-home tests accurate? I'll be brief here. We certainly talked about it in the past. They aren't as sensitive as the PCR test that you will get. They go from as low as 50% to up to 80% or so with the PCR test, but they are very specific. If you have a positive at-home test, do not go out and repeat your test at the doctor's office to try to do a better test. The one at the doctor's office is not really any better at confirming you have it. So we've done, I think, the wildlife camera analogy. If you see something, it's real on those tests. So the idea that many tests are false positive is a common misconception, and you really need to treat those tests as positive. The fact that you take a test that's very, very specific and very likely to be true if it's positive, and followed up by a test that's not terribly great at finding it in the first place, and you get a negative test by that, you've just taken a much murkier result and allowed it to supersede the results of a much clearer black and white result. So we don't want to do that, because that will, and I've seen people get a test at home, be positive, and they say, I'm going to do it again. I don't think this is real. And they get a negative test because a lot of them are falsely negative. And so then they say, oh, I'm fine to go back to work. And that's really what you don't want to do. If you have a test that's positive, it probably really is the truth. Denise Lyons asked, what about studies showing remdesivir shutting down kidneys? It is true that remdesivir does have sometimes some liver and some kidney toxicities, and it's best not to give that drug, and we don't if they have substantial kidney and liver toxic problems in the first place. It is not the case that it is common that that happens. We treat very sick people in the hospital with remdesivir, and very, very few of them develop kidney problems or liver problems from the drug. Now, it does happen sometimes, because it turns out that people who are really, really sick and in the hospital will sometimes get liver and kidney troubles. So that's why you have to be careful about that. And that's why they did studies with this on people to compare people to make sure that it wasn't any higher in the people that got remdesivir than the people who didn't. And that number is quite low. It's not a common toxicity, but something, no question, that we do look at carefully. Just going to answer one more because time is about up. Tony Wiley asked, what about the rise of RSV, respiratory syncytial virus, in children? Do you think this is COVID manifesting itself in small children? I think the answer is no, it's not a COVID manifestation. It is its own clearly defined, widespread, long-known virus, respiratory syncytial virus. It can do significant damage, particularly to younger kids who have any sort of respiratory problems to begin with. It does significant problems in transplant patients who are adults. So it can cause a lot of problems. We've seen a few in the hospital of late. Kids are particularly seeing it. It's in doctors' offices. It's even in pediatric hospitals now. So it is a different virus, but just like the flu, it is going to cause potential problems in the wintertime. You won't know which is which. It's helpful to try to find out which one it is. There are tests for both. In both cases, you should try to keep kids apart in the household in that situation, keep them out from school if they have it, because both of these things are quite contagious. And I'm sorry, I'm going to do one more. Madeline Murphy asked, is there another variant on the way? And I think that's really a good one to end on, because I think that's the reason for some optimism right now. There is no Delta following our Delta. There is no virus out there tearing up another country on the way to us because it's more contagious. We don't see that right now. No other variants have come out that are more contagious and out-competing Delta. Now, that may be because there needs to be more time for Delta to wane a bit more because of immunity, both from previous infection and from the vaccine. Only then might a virus like Mu, like Lambda, like something else that's out there, Gamma even, come in because it is more resistant to our immunity. As I've said before, a slippery horse, not a faster horse. That may be the next generational advantage for the virus evolutionarily. So we might see that coming in behind it, and it's probably too early to see that. But the good news is that we hope we'll have a time here where Delta is leaving us and there's nothing right behind it, and we'll have a time where we can go back to relaxing some of the restrictions that we were already seeing happening, even as Alpha was leaving us before. But I think we have to be careful too, because we're also looking at a winter in front of us, as we mentioned. So there will be things that are advantageous to any virus, any respiratory virus, including COVID. So we hope that those things will balance out, and on balance, still allow things to get better. But it probably makes sense as we get into that colder weather at first, still to be a bit careful about our behavior pattern. If we get into December and we're doing great and the numbers are still falling, then that's going to be really, really encouraging, and I think a reason for significant optimism moving forward. Any other questions I can answer? Okay, thanks very much. Have a great weekend.